I'm Jae Jang, oculoplastic surgeon. I worked in Kimsai Hospital in Seoul, Korea. I will talk about the orbital wall fracture, past, now, and future. This review would be primarily focused on the management for orbital flow and medial wall fractures. Complete eye exam is necessary for patients with orbital wall fracture. Vision, intraocular pressure, slit lamp, pupil retinal exam, ocular motility. Orbital CT imaging is the gold standard for detecting and defining orbital fractures. The goal of reconstruction for orbital wall fracture is to repair bony defects and to restore normal function. The proper surgery and the right choice of orbital implant for reconstruction are essential. The surgical indications of orbital wall fractures are anophthalmos and limitation of eye movement. And the other one is orbital wall fractures combined with limb fractures. This is a large orbital wall fracture CT scan. Usually more than 50% is, we call that large wall fracture, is likely to cause clinically significant anophthalmos. This photo is inferior large wall fracture, this CT scan, medial wall large fracture, and the last one is medial wall and the inferior wall large fracture. The photo showed the large inferior wall fractures. 1 month after trauma, the anophthalmos was found in the right eye. Low photo, the female patient visited hospital 1 month after trauma because of anophthalmos here in the left eye. CT scan showed inferior large wall fractures in the left eye. After the anophthalmos was improved after reconstructive surgery, like this. Next indication of surgery is the limitation of ocular movement. First, in the large wall fracture, limitation of eye movement occurred due to marked downward displacement of inferior rectus muscle here. And entrapment of muscle or just periorbital tissue may restrict ocular movement and result in diplopia. This is a very small wall fracture, like here. This is trapdoor fracture. Trapdoor fracture is usually occurs. The second bone is displaced and then hinged back to more normal position. Entrapment of muscle and periorbital tissue may be occurred. This trapdoor fracture is more common in pediatric patients due to more elastic orbital bone. Oculocardiac reflex is more commonly encountered in trapdoor fractures. The symptom triad is bradycardia, nausea, and syncope. The child may be normal appearing eye until limitation of ocular movement is found. This type injury called usually the white eye blob fracture. Because of these symptoms, pediatric trauma patients who visit the emergency room are confused by brain disease and receive neurosurgery consultation before ophthalmology consultation. This photo shows the typical trapdoor fracture. CT scan shows a small wall fracture with entrapment periorbital tissue. We call that this is teardrop sign. And the patient had no clinical evidence of soft tissue trauma except marked limitation of gaze. The timing of surgery is immediate surgery and delayed surgery. The immediate surgery is necessary to release the entrapment muscle and tissue in the tract of fractures. And the majority of observed fractures are managed initially observation, then surgical intervention if indicated within 14 days of injury. The delay allows periorbital edema to decrease and can subsequent examinations. Ideal implant for reconstruction of orbital fractures must meet criteria of biocompatibility, stability, safety, intraoperative adjustment, and last one is low cost. Autologous implants are generally not preferred due to donor site and surgical issues. Alloplastic implants are non-absorbable and absorbable materials. Over the past 30 years, I have had experience with implants shown here in yellow color. Osteotrans has two components, absorbable one and the non-absorbable hydroxyapatite. This is Shilastic sheet, and this is Medipore, this is Barrier-type, and the Medipore combined with the titanium. Since 2009, I have mainly used Enion and Lepidosol absorbable implants. This is Enion CPS mesh plate, this is Lepidosol mesh plate, this is osteo mesh. Now I will show the cases of reconstruction. The 2001, I used Shilastic sheet for medial wall fracture. This is Shilastic sheet. This is medial wall fracture after the surgery, coronal view and axial view, like this. I use Medipore for inferior wall and the Shilastic sheet for medial wall. Medial wall, Shilastic sheet for medial wall and Medipore for inferior wall reconstruction. This is another case. 2009, I used the Medipore for inferior wall large fracture. This is muscle downward displacement after the surgery, like this and like this. Since 2009, I used observable materials for medial wall fracture instead of Shilastic sheet. This is medial fracture, pre-CT scan and post-operative CT scan. I use Medipore for inferior reconstruction and I use the MacroPore medial like this. This is Medipore inferior wall and MacroPore medial wall. And 2013, I used Medipore for inferior wall fracture. This is the turning point for me. Since 2009, I have been using observable implants for medial wall fracture. Through this experience, I decided to try using observable materials for inferior wall fracture surgery. In June 2014, I obtained a satisfactory result after surgery using an observable material in a patient with a large inferior wall fracture and medial wall fracture. Since then, I have some confidence that observable materials can be used for large inferior wall fractures. In order to cover the entire large wall fracture site with one implant, a very large implant must be made, and it is difficult to insert through the conjunctival incision. At that time, the double layer technique was used for large inferior fracture. And first, a wide implant was inserted to pick the widest fracture site here, first one, and then second, a long implant was inserted to pick the posterior fracture area like this. A male patient visited hospital for diplopia and tenderness at inferior orbit. CT scan showed orbital cyst around. This is maybe metaphor, previous inserted metaphor for inferior fracture 9 years ago. During the surgery, dark brown fluid gushed out and the metaphor was surrounded the fibrous tissue. This is removed metaphor. The observable implant was inserted after removal of metaphor and the cyst. This is 2 years later after the surgery. Many papers have been published on orbital cysts that occur after orbital fracture surgery. This is the second reason I used an observable material for reconstruction of orbital fracture instead of a non-observable material. Based on this experience since 2015, I have been using observable implants of any size of inferior fracture. This is very large inferior fracture to the surgery like this. This is another case, reconstruction of large fracture using a mesh plate. Like this is very large fracture after the surgery like this. This is my history of orbital implant for orbital fracture. Until 2000, metaphor was used for inferior fracture and elastic sheet for medial fracture. From 2009, I used observable material for medial fracture instead of elastic sheet. Until 2014, metaphor used for inferior fracture, but I always said that my turning point. After that, I used observable implant for inferior fracture since 2015. A survey was conducted on members of Korean Society of Ophthalmic Plastic and Reconstructive Surgery, the KSOPRS in Korea, and total 52 KSOPRS members responded to survey. More than 85% had more than 10 years oculoplastic experience. I asked how many block fracture surgery in a year. KSOPRS members responded, 58% said that they performed 20 or more orbital fracture surgery per year. And also, when you use only one implant, is it non-observable or observable? And 56% KSOPRS members use only one type of implant. 51% non-observable material only. 48% said that observable material only for orbital fracture. There was no difference in the proportion of users of observable and non-observable. I investigated the reasons for using 2 or more types of implant for orbital fracture surgery. The reason as follows. First, non-observable implant for adults and observable materials are used for children. Second one is observable materials are used only when orbital fractures are small. Here, many doctors use non-observable materials for large inferior fractures because the observable materials will not sufficient to support the inferior wall. However, based on my experiences, the observable materials are another option for the inferior fracture surgery. A traditional method is measurement of fracture site with visual inspection and manual cutting to the implant for surgery. The success of surgery is completely depend on the surgeon's experience and skill, but the implants that do not fit anatomical structure of a fracture site well can cause endophthalmos and displacement of implant. This is perfect reconstructive surgery after the 5 years later. The inferior large fracture metaphor used for inferior large fracture, pre-op CT scan and post-op CT scan. But this CT scan showed imperfect surgery. And pre-op and post-op CT scan showed that the posterior edge of implant was not located posterior ridge and slightly went downward position. This case may be occurred due to a difficult to locate posterior ridge here and the fear of optic nerve damage. The pre-op and post-op operative CT scan showed that the implant did not fit the posterior part of medial fracture site here. For these reasons, 3D implants are being introduced for orbital fracture surgery, and many studies have supported the need for navigation surgery to minimize damage to surrounding tissue and optic nerve during surgery. Due to the unique 3D structure of orbital wall, it may be difficult to design an orbital implant for complete fit the shape and the surface of orbital wall fractures. For these reasons, there are many trials for patient-specific 3D implant. This one is ready-made 3D implant based on the population data. Next one is production of patient-specific implant from 3D printed skull model with manually molded titanium implant. A 3D printed template used and accurately produced a PSI, patient-specific implant by the preoperative virtual 3D orbital implant model for fracture site. Template consists of two components, an upper and lower part, and the inserted into a press tool with implant material to replicate the 3D contour of the orbit. This technique was published by Korean oculoplastic surgeon, Dr. Sa. See 3D printing technology to produce fully patient-specific implant. Yes, I'm using optical implant template using a 3D manual printing to KS of PRS members. Only 17% KS of PRS members currently use a 3D implant. Surgical navigation systems are generally similar to a GPS as used commonly in automobile. Satellite is same localizer here, and the track wave from car is instrument or surgical probe here, and the CT scan is similar to roadmap. This table shows the advantage and the disadvantage according to the different tracking system. There are two kinds of tracking system. First one is optical and second one is electromagnetic. Optical is most accurate and large field is available, but the more expensive. Electromagnetic tracking system is easy to set up and less expensive, but the field is narrow and less accurate. Surgical navigation systems were developed for neurosurgery and now commonly used in various maxillofacial surgery because of reliability and high accuracy, but still remains high cost remains problem. The applications of navigation surgery in orbit are as follows: orbital fracture, thyroid decompression, orbital apex tumor, orbital foreign body, optical decompression. Navigation guidance provide enhanced precision, safety, interoperative position, and spatial orientation, and the minimal potential complications. I asked the KSO PRS members, are you using the navigation system? Only 30% currently use navigation system for orbital surgery. In summary, the goal of orbital wall reconstruction is avoiding the enophthalmos and restoring the normal function through the less traumatic surgery. The bony defect need an orbital implant with sufficient strength and optimal contour to support the orbital content. From my experience, I would like to inform you that using observable implants for large inferior fracture can produce good result. Customizing 3D orbital implants and navigation surgery may improve the accuracy of implant placement and lead to better surgical outcome. Thank you for your attention. This is my email. If you have any questions, please email me or via email. I will answer your question. Thank you for your attention.